بخشین که من باید انگلیسی حرف بزنم میذاره برای من آسون‌تره. میخوام بگم خیلی ممنون که منو اینوایت کردین و خیلی اکسایتد هستم که جزو این گروه Iranian Neuroscientists باشم. Today I'm going to be talking about diverse neural phenotypes in post-traumatic stress disorder and using these diverse phenotypes to inform targets for intervention. Like they mentioned, I'm at Emory University and I'm an affiliate faculty member in the neuroscience program at Emory. And I've been doing PTSD research for a pretty long time. So about 13 years, I would say this is when I started in graduate school. But beyond that, when I was an undergraduate, so just to tell you a little bit about myself, I was an undergraduate at Emory, and my goal was actually to become a physician. Like most Iranians, this was kind of the trajectory that I was expecting to be on, and that came through all the way until the end of my undergraduate career, when I realized that even after I took the MCAT, that this was not a career that was a best fit for me. And I thought about courses that I'd really enjoyed as an undergraduate, and the courses in neuroscience and psychology that I'd taken had really interested me, but I knew that I wouldn't be competitive to go into a PhD program without having done a whole lot of research in that field. So what happened was that I became a research assistant in a PTSD neuroimaging laboratory at Emory. And this became the experience that really shaped the rest of my career through interactions with people with PTSD and learning more about different imaging technologies. I started off with positron emission tomography and then moved on to fMRI. I got to see sort of how clinical manifestations were related to neurobiology, and it really fueled my interest in PTSD clinical neuroscience research. And, as they mentioned, I pursued a degree in clinical neuropsychology at Georgia State University. And after that, I did a postdoctoral fellowship, which was funded by NIMH with an F32 award, looking at neurobiological intermediate phenotypes for PTSD related to candidate genes that we think sort of mediate PTSD risk. And that prepared me for my early career as a faculty member at Emory. And I was funded by a K23 award by NIMH, and then more recently an R01. So there's been kind of a funding pathway that has helped support me in my career, and I've sort of landed in the School of Medicine. And I'm happy to talk to any of you afterward about sort of more about this trajectory and how I landed here. But sort of what I'm going to be talking to you more about today is PTSD biotypes. So different clinical manifestations of PTSD, like re-experiencing of trauma, hyperarousal, and attentional control abnormalities that sort of map onto neurobiological patterns that we can measure with fMRI. I'm also going to be talking to you about the effects of race-related trauma, including racial discrimination, because a lot of the people who've been participants in my research are Black Americans who've experienced a lot of racial discrimination. And at the very end, I'm going to be talking about mechanistic interventions that might be a good fit for particular PTSD biotypes. And just to sort of give you a sense of what my motivation is for doing this kind of research, it's really driven out of honoring trauma survivors to sort of characterize the range and depth of their responses, because there is such a heterogeneity in trauma response that I think really needs to be captured using a multimodal method. And just to start out about, trauma, trauma is a thing that is ubiquitous. And when I talk about trauma, I'm talking about experiences where you either you experienced something that was life-threatening, or you witnessed a life-threatening event, or experienced a serious injury, or it could be a sexual violation. And there are estimates that show that up to 90% of the US population has experienced trauma at some time in their life. And PTSD is actually not uncommon, especially when trauma exposure is more frequent. So national estimates suggest a relative minority of people develop PTSD in their lifetime, about 7%. But when trauma exposure is more frequent, like in the inner city, where there's neighborhood violence and things of that nature, rates of PTSD are higher, around 30%. And there's a group of people who don't meet full criterion, diagnostic criterion for PTSD, but have symptoms that are still functionally very impairing. We call this partial or subsyndromal PTSD. And these are clinically meaningful manifestations as well. And sort of speaking about inner city trauma, this is the context in which I've done most of my work, is through the Grady Trauma Project. This is a long-standing study of PTSD risk and resilience. So this study was started out by Carrie Ressler and Beck Bradley, a psychiatrist and a psychologist over at Emory, who were trying to understand genetic and environmental risk factors for PTSD. And so the people in the Grady Trauma Project are recruited in a kind of unusual way. So Grady Hospital is situated in downtown Atlanta. It serves patients who are mostly people who are low income, so people who can't really afford insurance. So the underinsured are overrepresented at Grady Hospital. And you can see in this chart that over half of the participants in the Grady Trauma Project have monthly household incomes of less than $1,000, with only 12% having monthly household incomes of $2,000 or more. So that speaks to the level of poverty that's in this population. And rates of trauma exposure, particularly interpersonal trauma, as you can see here, are pretty high. And so I was saying that the recruitment is kind of unusual in that people are randomly approached in the waiting areas of primary care, diabetes, pharmacy, different areas at Grady. And because the wait has been so long to see doctors, the research assistants have time to do informed consent and get an assessment of PTSD, trauma exposure, and other trauma and stress-related problems. And from that point on, participants may or may not go forward into other arms of the Grady Trauma Project, including the neuroimaging arm. So rates of PTSD are also pretty high. Nearly half of the people in Grady Trauma Project meet criterion for PTSD at some point in their lifetime. Major depressive disorder, similarly, slightly over a third of our participants have met criterion for major depressive disorder at some point in their lifetime. And when it comes to PTSD itself, it is a very heterogeneous disorder in terms of clinical manifestations. So these are the criteria for DSM-5, which includes clusters of symptoms related to reliving of the trauma, having nightmares, flashbacks, or being distressed when you're reminded of the trauma experience. Those are all re-experiencing symptoms, symptoms of avoidance of people, places, or things, or thoughts related to the trauma. Then there's a cluster of symptoms that's in itself pretty heterogeneous, negative alterations in mood and cognitions. And then there's hyperarousal, so increased physiological arousal that could manifest as sleep disruptions, high physiological startle response, that kind of a thing. So as you can imagine, there are many possible permutations that can lead to a diagnosis of PTSD, which led to this article being published in 2013 by Isaac Gallitzer-Levy, who found that there are, in fact, 636,000 ways to meet criteria for a diagnosis of post-traumatic stress disorder. So this really speaks to the heterogeneity of this disorder. And because symptom manifestations have been so mixed, and because the neuroimaging literature has been mixed as well with PTSD, there have been some conceptual models that have emerged to help explain these neurobiological and clinical differences. So Ruth Lanius and colleagues formulated this model of PTSD that's based off of emotional undermodulation or overmodulation. And what that means is that people who tend to have more of an emotional undermodulation profile are those who may have problems with extinguishing their fear responses or inhibiting fear-related responses. So these folks often have more symptoms of re-experiencing or hyperarousal. And in terms of neurobiology, they tend to have a heightened response in the amygdala, as well as the insula to trauma-related cues, and a attenuated response in regulatory areas of the brain, like the medial prefrontal cortex. And the opposite pattern is true for people with PTSD who have different symptom profiles, who experience dissociative symptoms like depersonalization or derealization. I'm going to be talking about these dissociative symptoms more in a few minutes, as well as emotional numbing or anhedonic symptoms of PTSD and analgesia. These people sort of represent an emotional overmodulation profile. So they have a heightened response in this medial prefrontal regulatory area of the brain, but a dampened response in the amygdala and the insula, areas that are involved with salience or threat detection. So based off of this conceptual model, I've sort of organized my talk today to talk about what I've seen in my own research, as well as the research of my colleagues. So while this way of thinking about PTSD is great, I think it still can be kind of improved upon. So I'm going to be talking about decreased emotion modulation and its relationship to re-experiencing and hyperarousal symptoms, but I'll also be talking about symptoms related to reward deficits or anhedonia, the emotional numbing symptom profile of PTSD. And I'll also talk about what they refer to as a heightened or increased emotion modulation profile that I would suggest also relates to a prefrontal insula amygdala disconnectivity kind of syndrome. And this kind of profile is best related to symptoms of dissociation. And there are some relationships to effects of race-related trauma. So I'm going to be talking about these biotypes in this way. And starting off with decreased emotion modulation. So the symptoms of PTSD that relate to fear responses, so reliving of the trauma or hyperarousal. These symptoms seem to be related to, like I mentioned, a disconnectivity between the ventromedial prefrontal cortex, which regulates the amygdala response. This has been a pretty consistent finding in the literature. And interestingly enough, treatments that address this disconnectivity between the amygdala and ventromedial prefrontal cortex, like prolonged exposure therapy, which help people learn how to extinguish this fear response in reference to trauma cues. These kinds of treatments have been related to an increased connectivity between the amygdala and VMPFC. So if you see down here on the bottom left, this is a recent publication by Fonzo and colleagues that was looking at prolonged exposure therapy compared to waitlist control and scanning people pre and post treatment. And what you're seeing here is that the people who were in prolonged exposure therapy, who learned how to extinguish their fear responses, had a higher connectivity between the amygdala and VMPFC compared to waitlist controls who were in the dotted line and had a decreased connectivity actually over time. So I'm probably going to spend the least amount of time with those with this VMPFC amygdala story of re-experiencing, but I'm going to be talking a little bit more about how this decreased modulation, decreased inhibition of fear is also related to frontoparietal or attentional control abnormalities in PTSD. So the data that you're looking at here is coming from a study that is using a pretty sophisticated clustering analysis to look at a group of veterans who were all trauma exposed and some of whom had PTSD. And they were looking at these resting state connectivity data and used a clustering approach to see what the neuroimaging data is, how the resting state data could be used to cluster people, and then using this clustering mapped these different groups onto clinical symptoms, including re-experiencing. And what the authors found was that there were two clusters that emerged from the resting state connectivity data with their algorithm. And what they found was that in the first cluster, this sort of represented a low symptom profile. So people who didn't have a lot of symptoms of PTSD. And in terms of their brain data, there was a kind of increased connectivity in networks like the frontoparietal control network. But sort of this is the opposite of the findings with cluster 2, which if you're looking at sort of the red being increased connectivity and blue being decreased connectivity, you can see that in cluster 2, there was a frontoparietal disconnectivity that was characteristic of cluster 2. And when they looked at symptom manifestations and how they mapped onto these clusters, they found that re-experiencing symptoms in particular characterized cluster 2 as compared to cluster 1, or participants who had no symptoms of PTSD at all. So, I will say, you know, in my career, I've focused a lot on attentional disruptions in PTSD, and have used kind of a multimodal approach to understand the nature and direction of attentional problems in post-traumatic stress. And one of the paradigms that I've used to assess attentional control abnormalities is this affective Stroop task that you're seeing over to the left-hand side. So, what happens with the Stroop task is participants see a series of images, and the emotionally valenced images could be either trauma relevant or they could be positive images. We also include neutral images, and these images are placed as distractors. So the goal of the task is to press a button that corresponds with the number of numbers that they see, and it flashes by pretty quickly in 400 milliseconds. So surrounding that stimulus is a distractor that could be trauma relevant, positive, or neutral in nature. And what we're assessing is, I'm sorry, what we're assessing is performance on this task, as well as response latency. So this is a Stroop paradigm. And in some conditions, the number of numbers is congruent with the actual number that's presented. In some conditions, it's incongruent. So that's where you see the Stroop effect. And that's what you're seeing here in the middle row. And so what we're able to see with this task as we're sort of varying the images, and what I did with this task, so this is a task created by James Blair, who was at NIMH and now is at Boys Town. I inserted images that are relevant to the traumas that people have experienced in the Grady Trauma Project to increase the ecological salience of the task. And what I found was that in this study, which represented my K23 study, I found that people with PTSD, as compared to controls, had a decreased response in this rostral cingulate area of the brain. So this is very much a component of a frontoparietal control network. And when it came to the performance on the task, I found that surprisingly, people with PTSD as compared to controls, they certainly did worse across the different conditions, but the comparison was only statistically significant in the context of positive images. So it wasn't in response to the trauma relevant images that they had the most errors, but actually the positive images, which was certainly a surprising finding, but I'll be sort of talking about the implications of that in just a minute. But you know, what I also looked at was not just PTSD as a group, but what were some correlations of the different clinical clusters of symptoms and how they related to response to positive stimuli in particular as compared to neutral stimuli. And this is just one example of a stimulus image on the left. And what I found was that the re-experiencing and hyperarousal symptoms of PTSD, there was an increased activation in response to these positive images in components of this frontoparietal network. And I didn't see this relationship with other symptom manifestations. So really re-experiencing hyperarousal, these fear-related symptoms related to this pattern of response in frontoparietal networks. that was kind of abnormal in PTSD compared to those with low PTSD symptoms or no PTSD symptoms. And so because this is a multimodal approach, I wanted to look at not just fMRI data, but wanted to see structurally, was there any difference in people with low or high symptoms of PTSD in response to this task, and sort of taking performance on the task, and particularly performance on these positive image trials, and relating it to white matter structural connectivity using probabilistic tractography. And what I found was that there were two pathways that seemed to be particularly relevant to task performance on these positive image trials. So what you're seeing here are probabilistic pathways that were reconstructed for the, so this method takes a streamline-based approach to look at white matter connections, and the seed regions for this approach were the hippocampus to the anterior cingulate, so reconstructing the cingulum bundle pathway, as well as the amygdala to the VMPFC. So looking at these pathways and how connectivity related to performance on the task. And what I found was that certainly there was this kind of disconnectivity in the frontoparietal white matter pathway that was related to task performance to these positive trials. And that was also relevant for the VMPFC and amygdala pathway. So both of these white matter pathways seem to be relevant to task performance. And when it comes to the cingulum bundle, this is a finding. So the relevance of cingulum integrity to PTSD was something that I found much earlier. So when I looked at, in this earlier study, a comparison of PTSD versus controls, there was lower fractional anisotropy, which is a kind of index of white matter microstructural integrity. And so this was lower in PTSD versus controls. But when I looked at symptom clusters in particular, it was re-experiencing symptoms that seemed to be the most related to lower FA in this posterior cingulum region. So really speaking to a frontoparietal and frontoparietal limbic disconnectivity that sort of characterizes attentional control abnormalities in PTSD. And because, these findings really related to positive stimuli and not trauma-related stimuli, this really got me more interested in reward-related dysfunction in PTSD. And when it comes to the symptom clusters, there is a group of symptoms that does reflect reward-related abnormalities in PTSD, and they are mostly social in nature. So feelings of detachment from others, social or emotional numbing, diminished experiences of positive emotion, as well as a loss of interest in activities sort of reflect anhedonic symptoms of PTSD. And this group of symptoms is really special in that they're particularly related to substance use problems, as well as other poor functional outcomes, including suicide attempts. And so I've looked at the relationship of these symptoms with functional and structural connectivity. And what I'm showing you right now is work that was done by a student at Emory, Niti Mehta, who looked at connectivity in a corticostriatal pathway that seems to be relevant to anhedonia more generally. So she took data from the Grady Trauma Project and looked at VMPFC and ventral striatum connectivity. So her advisor, Jennifer Felger, had found that this pathway in particular was related to symptoms of anhedonia and depression, and had also found that inflammation was related to this disconnectivity. And so what you're seeing here is findings that show that people who, in this group of participants from the Grady Trauma Project, it was those who had the high levels of inflammation shown by C-reactive protein. So it's an acute phase reactant that is a pretty reliable marker of inflammation. So what she found was that those who had high levels of inflammation in particular showed a decreased connectivity in this path. And so this was kind of a mixed group, but she found that this decreased connectivity in the high inflammation group was related to anhedonia in depressive symptoms as well as PTSD, so these numbing symptoms that I just mentioned. So this could suggest that there could be an inflammatory mechanism behind these symptoms of PTSD, and that this disconnectivity in this pathway could represent a diminished reward sensitivity that characterizes these symptoms. And myself and my colleague, Dr. Nate Harnett, who is over at McLean, Harvard, we wanted to look at in a different sample. So this is an emergency department sample. So people who had just experienced trauma. Are there white matter biomarkers that predict risks for the development of anhedonic PTSD symptoms down the road? So a pre-existing kind of white matter profile that could, predict risk for developing these problems, and sort of what are the patterns of white matter connectivity that, sort of changes that occur over time that correspond with anhedonic symptom of PTSD development. And so what we found was that in an earlier study, in people who were scanned very recently after they were exposed to trauma, who had just been recruited out of the emergency room, the people who had lower VMPFC amygdala connectivity tended to be the ones who developed anhedonic symptoms of PTSD 6 months later. Whereas, what Nate found was looking at changes in white matter over time. It was really changes in fornix connectivity that corresponded with change in anhedonia over time. So this was a really interesting finding. So we had previously seen this pathway, the uncinate fasciculus connecting the VMPFC and amygdala to PTSD more generally. But the fornix was a new finding that we were trying to sort of figure out, why would it be a hippocampal striatal pathway that would be involved with these symptoms? And it kind of makes sense that this pathway, the hippocampus to the striatum, has been associated with reward learning. So it could mean that the people who end up developing PTSD anhedonia over time may sort of have an abnormality in reward learning processes that occur around the trauma. So social contexts or interactions might be linked to feelings of mistrust and betrayal. And without more opportunities and more social interactions, people don't learn that, people can be trusted and pursue more of these kinds of rewarding interactions. So this could lead to this social anhedonia deficit. So this was certainly an interesting finding that we're looking to replicate on a larger scale. And so I'm going to move into dissociative responses in PTSD now. And dissociation is a phenomenon that can occur not just in the context of trauma, but across other disorders like anxiety and panic disorder. And just some manifestations of dissociation include feelings of depersonalization, feeling like you're outside of your body, or derealization, feeling like you are detached from your surroundings, or feeling like you're in a movie or a play. And these types of problems have been linked to a disconnectivity between nodes of salience networks as well as attention networks and somatosensory networks. So we think about these problems with dissociation to be related to kind of a deficit between nodes of interoceptive awareness. So interoception sort of refers to your ability to be aware of your body signals, as well as the correct interpretation of body signals and association with those signals and emotional states. Interoception is certainly something that we're learning a lot more about, is a process that's very relevant to different types of disorders, and including PTSD. And so I'm going to be sharing with you some data on dissociation and PTSD and this kind of pattern disconnectivity that I have observed. And just to show you very quickly, this is a study that was done, a systematic review that looked at dissociation across different types of disorders and patterns of structural and functional findings. And you don't have to go through all of this to sort of understand the basic idea that, so in the purple, you're seeing the functional changes. And I really want to highlight that there are a lot of positive functional changes that occur in response to dissociation, and in particular, frontal areas. So a major finding from the systematic review was that there was kind of a heightened response in frontal areas of the brain, including the cingulate, so these regulatory brain regions. And certainly, when it comes to my data, I've found similar types of findings. What you're looking at here is data from a study where we used the same attentional control task and looked at connectivity between the amygdala and the insula and the prefrontal cortex, and found that the people who had experienced trauma and high levels of dissociation had a decreased connectivity between the amygdala and the insula. And notably, this group of high dissociators, so people who endorse more experiences of dissociation, they also, they did better on an executive functioning task. So this was kind of a surprising finding. So they didn't have a deficit in executive control, but they were more impaired with the affective Stroop in response to trauma-related images. So there seemed to be an attentional control problem, but only in emotional context and not in this neutral context. And so one of my big interests is to sort of understand how we can use interventions that are mechanistically designed to target symptoms like dissociation. Dissociation is notoriously hard to treat. It's not very responsive to treatments like prolonged exposure therapy. And frankly, it's not really designed. These types of treatments, prolonged exposure, are not really well designed for dissociation. It's not an absence of prefrontal inhibition of the amygdala, oftentimes the opposite. So myself and my collaborator, Greg Siegel, who's at the University of Pittsburgh, were thinking about how to make an intervention like mindfulness, which is sort of designed to address attentional control abnormalities as well as interoceptive deficits, a little bit easier for people with dissociation to engage in, because people with dissociation often check out in response to emotion cues. And so what we kind of designed was a intervention that gives feedback when people are doing breath-focused mindfulness. So as the person is breathing, they're experiencing a vibration on their sternum that's coming through a wearable subwoofer. So we have a transducer that's translating the breath, and it could be through a microphone or it could be through a respiration belt. But they're getting that feedback through vibration on their sternum. And what this is hopefully doing, using a different pathway, so not a top-down pathway that's sort of starting with the cortex and moving down, but taking a bottom-up type of approach that's using stimulus-driven attention to help people engage in this intervention more easily and help them direct their attention to the breath, improving their attentional control. And the hope is also to be improving interoceptive awareness. So the idea is that this tactile feedback that's coming through the sternum is going through the lateral spinal thalamic tract. It's synapsing over in the brainstem and moving towards the insula, which is a hub for interoception, as well as moving from that interoceptive state to a heightened attentional control state. And so what we're able to see with our pilot study is that people who were receiving this vibration feedback actually showed more of an improvement in their interoceptive ability. And this change in interoceptive ability corresponded with decreases in dissociation over time. This is kind of what you can see here with the red group having a steeper slope, a bigger change in interoception that corresponded with a change in dissociation over time. And we also found that when it came to like brain networks, decreased responses in nodes of the frontoparietal network actually corresponded with improvements in task performance on the affective Stroop. And it also corresponded with decreases in dissociation. So there seems to be and increase efficiency in this frontoparietal network. So it doesn't have to work as hard to get people engaged in this attentional control task. And so I'm going to just very briefly mention the relevance of this type of intervention to the types of neural network profiles that we're seeing in response to race-related stress. So using the same affective Stroop paradigm, we looked at relationships between experiences of racial discrimination in response to trauma cues in this task. And what we found was that people who experienced more racial discrimination actually had a heightened response in the ventromedial prefrontal cortex, which is sort of highlighted here, as well as the ventral visual stream. And so this was an interesting finding because the experiences of racial discrimination, so this this pattern of finding, so people who had experienced more racial discrimination didn't do worse on the task. They actually performed better. This was definitely a surprising finding, but it could go to suggest that, people who have experienced more race-related trauma may show a heightened engagement in areas of the brain that are involved with modulation of response, as well as visual attention. But this can occur at the cost of effectiveness, at the cost of efficiency. So they may be just as effective at performing an attentional control task, but this might come at a cost because there may be an increased need for modulating emotional response all the time, which is a drain. And so, this may suggest that treatments like the breath-focused mindfulness treatment I mentioned earlier, that's supposed to sort of target efficiency of attentional control networks versus sort of an increased activation in those networks could be particularly helpful. And so the pattern of findings that I saw with this study really fits in with models of race-related stress that sort of suggests that racism is a thing that's distinct from what we think about regular trauma, like a single occurring type of event, or something that is a bit more focal in nature, but it's something that's more ongoing and stressful. And what can happen is that experiences of racism, it's an uncontrollable stressor that could be sort of kept alive in the brain through perseverative cognition. So people sort of take in that event and the stigma really, or the sort of invalidation that often occurs with it. So it's not just the impact of the racism injury itself, but many times the invalidation of people in the environment that can make it worse. And through perseverative cognitions, that trauma is sort of kept alive. And the person might be anticipating constantly further injury or insult. So there might be an increased engagement in visual attention regions of the brain, as well as an increased engagement in modulatory areas of the brain involved with regulating of emotion. And sort of short term, that can be effective, helping people get through situations that are difficult. Getting through their work, getting through difficult interpersonal circumstances, but it can really take a toll and can lead to problems like increased anxiety, post-traumatic stress, depression, and substance use. So to wrap things up, what do these data suggest? So again, I'm going to reference these biotypes that I mentioned earlier, with this decreased emotion modulation biotype being characterized clinically by more re-experiencing or hyperarousal symptoms, as well as attentional control abnormalities, so cognitively having poorer performance on attentional control tasks, and relating to VMPFC amygdala and frontoparietal circuits. And so people who sort of fit with this biotype might be a good fit for prolonged exposure therapies, which really capitalize on fear extinction learning. They may also benefit from treatments that are designed to enhance attentional control, the strength of attentional control. And I argue that mindfulness-based treatments are well designed to strengthen connectivity in attentional control networks. when it comes to reward-related biotypes, which really reflect social anhedonia, the relevant pathways are cortical striatal and hippocampal striatal paths. And, I can't say that I know exactly what would be the right treatments for people who have a lot of these symptoms, but I can say sort of, we have some data to suggest that inflammation could be a mechanism. And if that's true, and anti-inflammatory agents could be relatively successful as a monotherapy or an augmentation aid in treating these folks. And types of treatments that really focus on increasing opportunities for positive social interactions, like in vivo exposure therapy, could be well suited for people who have more of these symptoms. There are other things like oxytocin that could also, sort of play a role in connectivity of these networks and treating these symptoms. And finally, people who maybe show an increased emotion modulation biotype, which relates to disconnectivity between the prefrontal cortex, insula, and amygdala. And this could refer to dissociative experiences or effects of racism-related stress. This subgroup might do well with mind-body types of interventions, including mindfulness, that are designed to enhance interoception and attentional control without increasing the kind of cognitive load that's required to increase efficiency of systems. And, I'm not suggesting that this, mindfulness intervention is a way to eradicate the effects of racism-related stress. Absolutely not. It's really structural changes that need to be made and policy changes that can really sort of address that. But what I am suggesting is that treatments that are designed to manage that kind of stress can be helpful. And I think that mindfulness-based treatments in particular are good at sort of increasing the ability to feel more in control of oneself and one's body and one's own attention without sort of increasing the amount of demand that's there, the cognitive load that's present. So I think I've definitely gone over my time. I want to thank all of the people that I work with, including in my lab at the Grady Trauma Project, my collaborators at Georgia State, McLean, Pittsburgh, and at Boys Town, and my funding sources as well, mostly NIH. Thanks very much.